Hello, good afternoon all. Welcome to the grand finale, day 7 of the CAMS Medmeet International UG Conference, an initiative of College Union 2020 Government Medical College Course. This will be the second half of the first session of the final round of medicine case studies. They have with us Dr. Dan, Assistant Professor, Department of General Medicine, Government Medical College Course. I humbly welcome you, sir. Here are the general rules for this event. The session will be conducted in two halves with different judges in each. This is the second half of the session. The first half has already been conducted. On both the halves, the participants will be given one short case each. First case study to discuss with Dr. Jayesh in the first half of the session. In the second half, Dr. Danish will take the with Dr. Jayesh. Then the second case will be discussed. All the participants will be 30 minutes time prior to preparation. Each participant will then be given 20 minutes time for discussion of the case. A time reminder will be given every minute. The participants are required to keep the camera and mic on while speaking. Please note the team we shall now start the session. Sir, may I call in the first participant?
Okay.
Please note this will be test number 1. Hello, test number 1.
Hello?
Can you hear me?
Yes, I can. Am I audible?
Yes. Can you
Yeah,
please on your
audible.
Yes.
Welcome.
Good afternoon, sir.
You can start presenting.
All the best, test number 1.
Okay, good afternoon.
Thank you. Yes, sir.
Yes, present.
Next slide, please. So a 55-year-old male, smoker and alcoholic, came with the chief complaints of progressive unsteadiness while walking of 6 months duration.
Okay.
There were no symptoms pertaining to higher mental function or cranial nerve dysfunction. There is no weakness, no sensory symptoms, no history of involuntary movements, no bowel or bladder symptoms.
Okay. So you have got a patient who is presenting with chronic unsteadiness for walking, isn't it?
Yes, sir.
Okay. So first, now we will analyze the symptomatology.
Yes,
then
sir.
we will move on to the other examination findings. So how you are going to approach to the above mentioned symptomatology?
Sir, as this is a case of ataxia, we like to find where the lesion is.
Okay. So first of all, you have got a person who is presenting with a symptom which is pertaining to a nervous system disease. Is it like
Yes, sir.
that? Okay. So in the nervous system, what are the levels of localizations? The first one is the topography. Okay. Then you have got the topography here is what? The ataxia. Okay.
Yes, sir.
So the next is your anatomical localization. Then you have to say what pathology is there. Okay.
Yes, sir.
The functional status. So here, your anatomical you told that the topography is an ataxia that you for a longer period of time.
Yes, sir.
So, okay. So you mean that the person is having an ataxia. What are the normal structural integrals that is required for a normal stance and a walk of a person?
Sir, first of all, a sensory system is required from
Okay.
the lower limbs and our trunk to maintain the posture. So it
Okay,
travels
sensory
through.
system. Okay, others.
So the sensory nerves traveling to the spinal cord. The
Okay,
posterior column
sensory.
tracts.
Okay, then.
So the cerebellum is required.
Okay, fine.
Basal ganglia is required.
Oh, fine.
Inner ear and labyrinthine system is required.
Then.
Uh, so the corticospinal tracts are required for
That is the
walking.
first thing. No?
Yes, sir.
Pyramidal, extrapyramidal,
Extrapyramidal
cerebellum, sensory, vision, and equilibrium. Okay.
equilibrium.
So among this, which anatomical structure is deranged in order to present as ataxia here?
Sir, in the sensory system is normal.
Okay.
Uh,
So suppose a person is having an ataxia of sensory system. What is the presentation?
so the patient will give a history of falling when eyes are closed.
Okay.
So like falling in the sink while washing his
Okay. Fine.
face.
Okay. Then what about the pyramidal?
So in pyramidal corticospinal lesions, there will be difficulty in walking
Okay.
and
What
the
is the
sensations will.
classical? What is the classical gait if there is a progressive spastic paraparesis for a longer period of time? What specific gait pattern that may exhibit the person?
Sir, in spastic hemiplegia, there will be circumduction
Not
gait.
in paraplegias.
Sir, in paraplegias, there will be
It is not paraplegia, paraparesis. They will
paraparesis.
walk now.
Yes,
So
sir.
have you heard of scissoring of gait?
Yes, sir.
Okay. Okay. Then
Crossed
what
legs.
about? Okay. So the LMN or UMN lesion can present with unsteadiness while walking. Then cerebellum. Okay. So do you think here it is a cerebellar problem?
Sir, if the gait is wide based and then we should think of cerebellar lesion.
Okay. What are the different types of ataxia of cerebellar origin?
Sir,
How do
sir,
we approach to ataxia of cerebellar origin? Do you think it could be a, what is the peculiarity of symptomatology that pertain to a cerebellar hemisphere pathology, or if it is a Permian lesion, or if it is a pedunculaar lesion?
sir, in cerebellar pathologies, there will be hyperreflexia, hypertonia with hyporeflexia.
No. My question is no. Suppose a person is having a hemispheric problem. What peculiarities in movement, and gaits the person may have?
So the person will sway towards the side of the lesion
Okay.
in
In a
case of.
Vernian lesion, what will happen?
So there will be truncal ataxia. The patient will
Okay.
won't be able
Then what
to.
will happen to a pedunculaar pathology?
Sir,
You have got three peduncles now.
yes, sir.
So,
So there will be ipsilateral ataxia because of ventral
okay.
spinocerebellar tract
See, in,
involvement.
in, in peduncular lesion, you may get combinations of cranial nerve, long tract symptomatologies, and
Yes, sir.
ataxia. Okay.
Yes,
If
sir.
it is a Vermeer lesion, you will get a truncal ataxia as
Truncal
well as,
ataxia.
and the truncal ataxia, and there will be tremor. Okay. Head tremor will be there. Then in cerebellar lesion, the person will, in hemispheric problem, the person will fall to the same side.
Side, same side.
Okay. So, do you think all cerebellar lesion the person will fall to the same side?
Sir, if there is bilateral cerebellar lesion, then there won't be
Any
side
any any
predisposition.
cerebellar pathology where the person will fall to the opposite side?
So,
In tonsillar lesions, okay. In tonsillar lesion, the person will opposite side. Okay. So your patient is having a disease may be affecting what a hemispheric pathology on both sides, or okay, the person is having difficulty in walking, but no, there is no truncal ataxia as per the history and all. So maybe hemispheric pathology. So unlikely a peduncular pathology. Uh, okay, so what pathologies you consider in such an elderly male who is coming with ataxia like that? What
sir,
was the
as this patient is alcoholic, so we can think of alcoholic cause.
okay, alcoholic, what alcoholic problem? What pathology in the cerebellum that alcohol will result in?
Sir, So cerebralitis, alcoholic cerebralitis.
Cerebralitis. Okay. Then
So,
other pathologies, since he's an elderly male.
so there can be uh, so stroke,
Okay, stroke is an acute
stroke.
event. Now we are dealing with an ataxia, which is of a longer duration, which is called as a chronic ataxia.
Chronic
So,
ataxia.
okay, so what are problems you may get now? Suppose it's a tumor. Have you heard of Have you heard of cerebralitis because of paraneoplastic?
Yes, sir.
Okay, paraneoplastic cerebellar pathology,
Yes, sir.
paraneoplastic cerebralitis.
Hmm.
Okay, so it could be a tumor, it could be a vasculitis, it could be a lesion like a paraneoplastic cerebralitis. Okay, even toxin mediated like
Yes, sir.
alcohol. Okay. So in that background, you move on to your general examination. What all findings are there in the general examination?
Next slide, please. So on examination, the blood pressure is 116 by 80 millimeters of mercury in supine position,
So
whereas
what
in
is that blood pressure? No, you have got a blood pressure which is what in the range of a 116, and the other the supine, and you have provided two values. A value
yes,
which
sir.
is what in the standing
Si-
or sitting, and the other is in the supine. So what
Yes,
does
sir.
that BP giving a clue to you?
So here, the systolic blood pressure is falling more than 20 millimeters of mercury, and
So
diastolic
what?
is one.
Okay.
So
So
orthostatic hypotension
okay.
is.
So in this scenario, a person, no any other general examination finding that he is having.
So he's having clubbing and gynecomastia and
Okay.
pigmentation of palmar crease.
Okay, so can you correlate each of these with the clinical history?
So clubbing is present. So I can think of paraneoplastic cerebralitis.
Okay,
So
which
as he is alcoholic, so there can be liver failure with chronic liver disease leading to gynecomastia.
okay,
So and pigmentation of palmar crease is pointing towards Addison's disease or vitamin B12 deficiency.
okay. So here, do you expect an Addison disease here in the scenario?
So with hyperpigmentation and orthostatic hypotension, we can think of that.
Okay, why this person should develop an Addison's?
So, there might be vasculitis or a cerebrovascular
Okay,
accident
okay. This person,
leading
what
to.
is the most common primary malignancies which can involve the cerebellum as a
So,
paraneoplastic manifestation?
so primary malignancy, there can be medulloblastoma.
No, no, my question, no. Suppose that there is a primary malignancy elsewhere. What what all paraneoplastic manifestations of the primary disease of the some any organ, no, can have a primary malignancy, and it can present with a paraneoplastic manifestation. Here the person may be having a paraneoplastic cerebellar disease. So what primary can present with a paraneoplastic cerebellar disorder?
Uh, lung tumor can present as.
Okay. So can you have Addison's disease in lung malignancy?
So Cushing's is more likely as paraneoplastic in lungs.
Okay, see, bronchogenic carcinoma, you may have 25% of patients may have adrenal metastasis. That is bilateral adrenal metastasis. So in
Yes,
that
sir.
scenario, you may get what? Gynecomastia, as well as you may get this adrenal insufficiency. Okay. So
Yes, sir.
okay. So what are the other? Suppose this person is coming to you with an altered sensorium, and you think the person is having a bronchogenic neoplasm. What are your possibilities?
Sir, the person might have landed in metabolic encephalopathy.
What metabolic encephalopathy?
Uh, so due to hyperuremia, hyperammonemia.
Any other common, because now we are thinking of a lung lesion. Have you heard of SIADH?
Yes, sir.
What electrolyte abnormality will it present with?
Sir, the ADH will be increased, so antidiuresis will increase.
So what electrolyte abnormality?
Sir, hyponatremia, dilutional
Okay,
hyponatremia.
suppose any other electrolyte abnormality in bronchogenic neoplasm which can present with altered sensory.
Sir,
The eye finding may be a band-shaped keratopathy.
sir,
The person may present with recurrent moans and groans, abdominal pain. ECG will show a certain finding. What is that electrolyte abnormality? Have you heard of hypercalcemia?
yes, sir.
Parathyroid related protein.
Yes,
Okay, so again, so there are even brain metastasis. Okay, so you have got metabolic as well as structural neurological problem to explain for this. So any other paraneoplastic manifestation you may think of in bronchogenic neoplasm?
Sir,
Other than the cerebellum involvement. Suppose the person is telling you that I am having a difficulty in walking and that is ascending up and the reflexes are sluggish, an element type of weakness. What problem you may anticipate?
sir, peripheral neuropathy.
Okay, okay, peripheral neuropathy. Any other disorder? And the person late develops difficulty in swallowing.
Sir, bulbar
Have,
palsy or
have you heard of Eaton-Lambert myasthenic syndrome?
yes, sir. Yes, sir.
Okay, so when you are having a person like this, you should think in each and every direction. Okay,
Yes, sir.
so suppose you take a chest X-ray and you may get so many findings. What is the specific radiological finding to say that there is a upper lobe collapse in radiology? Any named find?
Sir, the horizontal fissure will be concave upwards if
Okay.
there is upper lobe collapse.
Okay. What is a name for that?
Sir, phantom tumor or horizontal fissure
What
sign.
is golden S sign?
Sir, upper lobe collapse,
Okay.
right side.
What is left Sichel sign in radiology?
Sir, left.
Left Sichel sign.
Uh,
See, this is for right
left
upper
side.
lobe, no? The
Yes,
other
sir.
for left upper lobe. Okay, so you
Uh,
read the radiology. Okay, so
yes, sir.
okay, so now you told the person is having some Addison's disease, no? Okay, I'm giving you a scenario to assess your knowledge and all. So we have discussed the history, the findings and all. Now move on to little bit on treatment aspect. Okay, so person you are the person is admitted with history of edema, and you found out that the person is having hypothyroidism. The TSH is nearly 150, and you have given him thyroxine. And immediately after giving thyroxine, the person is found to be in state of collapse, and his blood sugar got reduced, and he is becoming sweating, and he is developing his what his BP is
Sorry
getting
for
reduced, and
interrupting.
he's
5 minutes more.
okay, he's getting collapsed. So, what scenario you may think of?
Uh, sir, sir, post glandular syndrome.
What
Sir, post glandular syndrome.
means?
Uh, Sir, after sir, in hypothyroid patient, if we give thyroxine, then there is hypotension and hypoglycemia.
Okay, so I didn't get what is the problem actually? What he has developed?
Sir,
So, how you are going to manage that person? What treatment you will provide?
sir, he can either be in mixed edema coma if he is presenting like that.
Okay, but you have given thyroxine, no? After
Yes, sir.
giving thyroxine, he deteriorated. So, what may be the scenario? You got no person is having hypotension, hypoglycemia. So, in a hypothyroid person, if you are giving thyroxine, the basal metabolic rate will increase, and the
Yes, sir.
person is going for an Addisonian crisis.
Yes, sir.
Okay, so if you are so in that scenario, you have to suspect a polyglandular syndrome, and you have to give
Polyglandular
what?
syndrome.
You have to. I thought you mistook the word, no? Polyglandular
Yes,
syndrome.
sir.
Okay, so actually, it's a poly. It may be a polyglandular syndrome where
Polygonal.
you have to give the steroids first. Okay,
Yes, sir.
so suppose what is the lymphatic drainage of lung?
So lymphatic drainage of
Lung.
uh, so the thoracic duct drains the lymphatics from the thorax and the mediastinal structures.
Okay, see the right upper lobe, the right lung, and the left lower lobe drains toward the right supraclavicular, and the left upper lobe drains to the left supraclavicular. Okay, so okay, so that was very interesting. Okay, to discuss with you.
Yes, sir.
Okay, so um, any doubts or anything on this? Anything to be discussed more? And the any, I think, is there any more findings or anything that is given in the question?
So there is gaze evoked nystagmus present.
Okay, so that is indicative of what?
So cerebral lesion.
Okay, so suppose now a person is having an adduction palsy and the abducting eye shows nystagmus. What is your interpretation?
So medial longitudinal fasciculus
Okay, that means
lesion.
there is a internuclear ophthalmoplegia.
Internuclear. Yes, sir.
So what is superior INO and what is inferior INO?
Sir, superior INO.
Okay, so leave it. Suppose now, what are the scenarios where you will get bilateral INO?
Sir, in Webino syndrome, you can have bilateral INO.
Which one?
Sir, Webino syndrome, wall-eyed bilateral
So,
INO.
okay, so very more common is what? No, the multiple sclerosis.
Yes, sir.
There is a pathology, no, wall-eyed
Yes, sir.
binocular internuclear ophthalmoplegia. Okay, okay, so okay, fine. Okay, that was a really nice session. Okay, so thank you.
Thank you, sir.
Okay.
Thank you, text number 1. You may leave the meeting now.
Thank you. Thank you, sir.
Yeah. Sir, please note that is text number 1. I call in text number 2.
Yeah, yeah.
Sir, text number 2 will be joining shortly.
Okay. Where is 2?
He'll be joining shortly, sir. Hello, text number 2. Can you please on your audio and video? Hello? Text number 2.
Hello.
Hello?
Hello.
Hello?
Hello. Yes. Am I audible?
Yes, you
Yeah,
are
yeah.
audible.
Audible. Yeah, fine.
Okay, all the best.
Yeah. Thank you.
Okay, you can present.
Good afternoon, sir.
Good afternoon.
I have been given the history of a 60 years old female who is having paresthesia and weakness of both the lower limbs for a period of 2 year duration.
Okay.
There are no symptoms pertaining to the higher functions or cranial nerve dysfunction. Symptoms progressed with sparing of the upper limbs. Only complaining of heaviness of also complaining of heaviness of both the lower limbs for 6 months, and there are no bladder or bowel symptoms.
Okay, so you have got a person who is coming with sensory and motor symptoms, isn't it like that? So which
Yes,
system is involved here?
the central nervous system is involved.
Okay, the nervous system is involved. Is it like
Yes.
that? Okay, so
Sorry.
if it
Yeah.
is a nervous system, so what is the topography of presentation?
Uh, 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 the
In what pattern the
yeah.
presentation is there?
Uh, uh,
It's
there
the
is uh, uh, there is involvement of weakness of the lower limbs, sparing the
okay.
upper
So
limb. So it is a
okay, what you so you call it as
paraplegia.
okay, paraplegia or paraparesis. Okay, depending
Paraparesis.
upon the degree of weakness. Okay, fine.
Yes,
So
sir.
you are having a person who is having paraparesis. Now,
Yes, sir.
the next question is now, is it an upper motor neuron type or is it a lower motor neuron type? With this history, what do you think?
It's an upper motor neuron type.
Okay, fine. So how could you identify that it could be an upper motor neuron?
There is heaviness of the limbs which is associated.
Okay, fine, good. So this person is having what? Heaviness of both lower limbs. Even though he is having
Yes,
weakness, he feels that the wood is very stiff and heavy. That
yes,
indicates
yes,
that's a symptomatology which is pertaining to spasticity. Is it like
yes,
that?
sir.
Okay, what else history you could have asked if he's having stiffness and all? You could have asked what symptom? Any other symptom to indicate spasticity? Any other symptom? Have you heard of flexor spasms? Flexor
Yes,
spasm, which is a counterpart of what? Clonus. Okay, so the person, suppose he keeps
yes,
his
sir.
leg somewhere suddenly tapping on, or suddenly he is keeping on the floor, no, the leg goes for what?
Yes.
Clonus. So
It will
that
go into clone.
is so that is called as flexor spasm. So a lady who is having what symptoms in the form of motor and sensory. So what is your approach to sensory symptoms in neurology?
Uh, as far as the sensory symptoms go, I would think I would first like to localize whether there can be involvement of the cortex or whether there is involvement of the like the level which is involved. Now in this particular case,
Okay,
the cortex.
here this person is having some sensory symptoms. Is it like that? So,
Yes,
do
sir.
you think it is a positive sensory symptom or a negative sensory symptom? Suppose a person gives some sensory symptoms. No, our first aim is what to identify whether it is positive or negative. What we call it as a positive sensory symptom. A positive sensory symptom means the person is
I
having
yeah.
a symptom even without what the person is having. A positive means even without external stimulus, if the person is having some sort of sensory feeling, it is called positive. So even
Okay,
with
sir.
an external stimulus, the person is not able to perceive, it is called as a negative one. Okay, so you have got two sorts of
Okay, sir.
positive sensory symptom. Which are those? It's very easy. No? One is a pins and needle sensation, and the other is a
Uh,
burning paresthesias. Okay.
okay, sir.
Okay. So suppose it is a burning paresthesia, what does it indicate in neurology? It's indicative of a spinothalamic tract or short fiber.
Involved.
Okay, suppose it is pins and needle sensation that is indicative of a large fiber or posterior column. So, if a person is presenting with paresthesia, it is our duty to ask to delineate whether it is any of these. So, our
Okay.
person is having an upper motor neuron lesion with a sensory symptom, and there is no definite level that they have mentioned. Okay, they have
Yes.
spared the upper limb also. Okay, so
Yes.
where you, based on this motor and sensory symptoms, where do you want to localize? Is it a cortical? It's, you told it's an upper motor
Uh,
neuron one.
yes.
So, so it's a is it a cortical one? Is it a
No, it
brainstem?
is not a
Is it?
cortical one.
uh,
It has been clearly mentioned that there are no symptoms which are suggestive of
Okay.
same, and there are no even cranial nerve
So
pathologies.
you mean it is a spinal cord disease, no?
Yes, sir. Yes,
Okay.
sir.
So in the cord, no, you have got two levels of localization. One we call it
Yes.
as the horizontal
In term,
localization, and the other is a vertical extension. Here
yes,
you
sir.
have got no definite vertical level. You can't identify a definite vertical level
Yes,
here
sir.
from based on the history. Is it like
History.
that? Okay, fine. So based
Uh,
on the symptomatology, what all uh, what all tracks you can identify here as involved.
okay. Over here there is a motor weakness, so there can be pyramidal there is pyramidal tract involvement which can be there.
Okay.
Uh, also and also as far as the sensory symptoms are concerned, there can be anterior spinothalamic and the posterior column which may be involved.
Okay, you so there could be either a spinothalamic tract or a posterior column. So there are
Yes.
three tracks are involved on both sides from history.
Yes.
Okay, but we can't localize which level
No,
it is.
yeah.
Okay, fine.
Yes.
So with history, no, you can say only like this, no. So do you think it is a could it be a compressive spinal cord lesion or a non-compressive one?
It is more likely to be a non-compressive type.
Why it is non-compressive?
Uh, it has been over a period of about 6 months. It is not
See,
not a recent
how
acute.
okay, so see, can you distinguish this based on one regarding the pain, second motor, then sensory, then you have got bladder. So based on these
Yes.
four parameters, are there no any points in this history which is more suggestive of a non-compressive or compressive?
There is there is no radicular form of pain.
Okay. Okay. So what is your so you have got you mentioned regarding pain. What are the different sorts of pain in neurology? You have got a radicular, funicular, and integumental.
Uh, uh, ra- ra-
Okay. So among
okay,
this,
sir.
which pain goes for a compressive lesion, an extramedullary compressive lesion, and what goes for a
Radicular pain.
okay? So integumental.
Uh, for non-compressive.
Okay, so integumental and radicular goes for a compressive lesion because
Okay.
integumental is because of the structures in the near the spinal cord. That is the vertebral body, the spinous process. Okay, suppose the spinous
Okay.
process, the ligaments are involved, you will get pain, and that's called a localized pain or integumental pain, which has got a localizing value as well as the radicular pain. It has got a high localizing value. So what about funicular pain?
Okay. Yes.
So funicular pain has got no localizing value. That is usually seen in intramedullary lesions. Okay, fine. So why this pain, radicular pain, increases on coughing and sneezing? Okay, so okay, so this person is now history. You can say it could be a non-compressive. Okay, fine, agreed. Now, if you move on to because little bit data is available in history. No, so we move on to what the examination, and we will finally localize the disease. Okay, so after the whole examination that's given to you, what is your impression? So the findings that is given to you are what this person is having higher
More likely
function
suggestive
cranial
of
nerves.
an UMN type.
Okay, so here you are this the examination findings now to summarize the person is having a normal higher function. The cranial nerves are normal, isn't it like that?
Normal.
Yes. Okay, so the cranial nerves are normal and the motor system. What is the power?
Grade 4 bilaterally.
Okay, so there is only paraparesis. Okay, then on the top of that,
Yes.
the person is having what is the type of reflex
Uh,
that the person is having?
Exaggerated deep tendon reflexes.
Okay, so you have got an exaggerated deep tendon reflex and you have got a bilateral extensor plantar, isn't it?
Plantar
Yes.
extensor.
So is it indicative of
Yes.
a pyramidal lesion?
Uh, it is however the ankle jerk is absent bilaterally, so it may be possible that the pyramidal is also extending into even the extrapyramidal may also be getting involved
Okay, so in view of
gradually.
so you are saying that the angle jerk is lost. The reason may be extrapyramidal involvement.
The lesion, there is definitely a pyramidal tract involvement, but
Okay,
even the
that's agreed.
extrapyramidal tract may have started.
Okay, so we will discuss that. Okay, later. Okay, so first you summarize now the person is having a pyramidal. Then what else? Sensory in the form of what? What?
He is having rhombox sign positive, so dorsal column tract may also be.
Okay, so posterior column is involved. So what about pain and
Yes.
temperature?
Pain and temperature is by the anterior spinothalamic.
No, no. Is it preserved here?
It has not been mentioned.
Okay, so if it is not mentioned, no, that may be what normal. So if a person is
Normal.
having, okay, so if a person is having only what a posterior column involvement as well as a pyramidal tract disease, and you are having what an absent angle jerk, no. So
Yes,
what are
sir.
the reasons for an absent angle jerk and other reflexes are normal or exaggerated? Angle jerk is only absent. Why? So elderly persons, no,
I
you
don't
may
get
get an angle jerk which may be absent, but here your posterior column is what also gone. So any large
yes.
fiber neuropathy, the person can have what a reflex loss. Is it
Okay.
like that? So the person is having. So if you take a, so if you take, so do you want me to draw and show that and show so that no the discussion will be much more better? I think so. Okay. So
Okay, sir.
so I think you can see. So
Yes, sir.
so suppose this is the the central canal.
Yes, sir.
So you have identified one problem to be involving the corticospinal tract, that is bilaterally. Okay.
Yes.
So
Yes.
this, so this corticospinal tract is involved here. Now you have got another thing that you have identified is what? The posterior column. Okay.
Yes.
So here posterior column is also involved. So what sort of a disease is this? The person is having what sort of a spinal
Posterior.
cord disease? So you call it as
Posterior cord
posterior.
syndrome.
See, posterior cord
Posterior
syndrome.
cord syndrome.
So this is posterior. That I agree. Okay, but this is posterior, but this is anterior, and here it is what lateral.
That.
Okay. So do you think it is a posterior? If it is posterior, it will involve only this posterior column tract. Suppose now you have involvement of the lateral, what? The lateral tract. That means the
Yes.
corticospinal tract. And this is posterior column. So that means it is a what sort of a disease you are dealing with? You are dealing with a posterolateral
Lateral.
cord syndrome.
Okay, sir.
So if it is a posterolateral cord syndrome, which are the scenarios where you will get a posterolateral cord syndrome?
Subacute combined degeneration of the spinal cord.
Okay, anything else?
Friedreich's ataxia.
And Friedreich's ataxia, you will get absent angle jerk and uh, what extensor plantar, but not a
Yes.
posterolateral cord syndrome. It is not a posterolateral cord syndrome. Okay, Friedreich's
Okay.
ataxia is another ataxic syndrome. Okay, it's a chronic
Okay.
ataxia. Okay, and you will get The finding is absent angle jerk and extensor plantar and so many other findings you will get in Friedreich's ataxia. Okay, so that will not come under this category. So any other thing? Have you heard of
Okay.
HIV myelopathy, or we call it as the vacculopathy? You have got yet another scenario, HTLV1 associated disease, myelopathy,
Yes, sir.
and here you have got yet
Yes.
another tropical spastic paraparesis, vitamin E related. Okay, tropical spastic
Okay, sir.
paraparesis, HTLV1, vitamin E, anything else with any metabolic abnormality. Suppose the person presents with neutropenia and thrombocytopenia, high levels of zinc, then you call it as hypocupremia. Okay, copper deficiency, hypocupremia. So these are the reasons for what a subacute combined degeneration, HIV, HTLV, vitamin E. Okay, so posterolateral cord syndrome. Okay, so
Yes.
that's how we approach to a case with posterior and
Sorry for
lateral.
interrupting. 5 minutes.
Okay, now,
Okay, sir.
okay, so
Hello.
uh,
Hello.
yeah, 1 minute, wait. Okay, so we were discussing the posterolateral cord syndrome. Now I'm giving you another scenario. A lady is coming to you with history of recurrent ulcers over the hand on both sides, which is painless, and she complains of what? A difficulty in walking. Okay, and you are seeing wasted
Yes.
hand on both sides. What could be your thought process? Have you heard of syringomyelia?
Yes, sir.
Okay, so suppose no another person is coming to you with a history of um, drooping of one eyelid. Okay, drooping of one eyelid,
Yes.
and no you are seeing what? Drooping of one eyelid, and the person is having uh, paresthesia and wasting of the thinner aspect of hand, and you are getting a right supraclavicular lymph node. What you may consider? And he is also
It can
having
be
an
because of
SBQ.
Pankos tumor compressing the.
Okay, what is okay? You mean it's a Pangos tumor? Okay, so what is your
It can
idea
compress
on?
upon the brachial plexus
Okay, fine, good. Okay, so uh, shall we discuss
as
something on
well as the
SPC?
sympathetic symptoms.
Okay, fine, good. So
Yes, sir.
okay, so what? So see, which are the three cranial nerves which may be getting involved in an SVC syndrome?
The 10th nerve.
Okay, how?
Along the course of SPC, the vagus would.
Okay, the recurrent laryngeal nerve, isn't it?
Okay. Yes, sir. Most.
Then,
Yes, sir.
then the sympathetic trunk. Anything else? The phrenic nerve.
Okay, sir. Yes, sir.
Okay. Okay. So, uh, see, a person is coming with history of a chronic smoker who is coming with history of progressive dyspnea. Okay, of 2 months duration, recurrent episodes of hemoptysis, and catching chest pain over the back. And now he is admitted with weakness of both lower limbs and intense pain over the back, and he is not able to perceive sensation below the level of umbilicus. What you may think?
It can be some compression.
Okay, it could be a very good. It could be a compressive. Yes, compressive,
Compressive neuro.
compressive See, the lesion is
Neuropathy.
neuropathy or myelopathy? Compressive, compressive myelopathy. That's it. It's a compressive myelopathy. Fine, good. Suppose now, shall I ask some others with some other system?
Yes, sir.
Okay. Okay. So, what is your understanding of the splitting of second heart sound?
The second heart sound consists of two components. We have the A2 P2 component. During inspiration, there is an increase in the venous return which occurs uh, to the right side of the heart.
Okay.
Hence the
See, what is
pulmonary component gets
pulmonary hangout interval?
yes, sir.
What is
Yes, sir. Hello.
pulmonary
Pulmonary
hangout
hangout
interval?
interval.
What is pulmonary hangout interval?
It is the interval which is present like after immediately after the second heart sound when the blood the valves do not the blood flows despite end of the systole which occurs. So it depends upon the distensibility of the valves and also the pressure gradient which is present. So the pulmonary valves have a more hangout interval as compared to the aortic valve.
Okay, actually, okay, that's okay, fine. Actually, the aortic valve will close by what 30 milliseconds after the expected closure,
Yes,
but the pulmonary valve will take much more time of nearly 90 milliseconds. So the pulmonary
yes,
system hangs out than
90
that
to
of the
120.
aortic system by a period of 60 milliseconds. Okay, that's how you are getting what
Yes, sir.
the splitting, and it is more on what
Split
inspiration than on expiration. That's it. Okay,
expiration.
so okay, so what is the classical radiology of an atrial septal defect?
Uh, Radiological finding in atrial septal defect.
Yeah.
Uh, there on radiology, there will be prominent pulmonary vascular findings which
Any
I can get.
peculiar
There can
name?
be
Any peculiar name for the radiology? What is jug handle appearance? Have you heard of it?
jug handle appearance because
Okay.
of the prominence of the descending pulmonary artery.
Okay. Fine. Now, okay. So something on management. So suppose a person is having atrial fibrillation. Okay.
Yes, sir.
See. Okay. What is the other name for atrial fibrillation?
Sir, I don't know the other name.
Okay, see what is the difference between atrial fibrillation and other arrhythmias? Suppose a person is having VT
It's
and
irregularly irregular.
it's not like that. Do
Uh,
you discharge a person
with
with a VT and all?
an
See,
apex with
see,
more than 10. Apex
only
percentage with
after
more than 10.
only after you can in most of the arrhythmias, no, you can return back the arrhythmia to a sinus rhythm. Is it like that? It's all arrhythmias. But in atrial fibrillation, it is very difficult to
Yes, sir.
turn back to a normal sinus rhythm, even with chemical or
Normal.
mechanical. Okay, so therapies. So that is why
Okay.
it is called a absolute arrhythmia. So the other name is arrhythmia absoluta. Okay, so that's an so
Okay, sir.
that is the first sentence that is given in what the American Association guidelines for what management of atrial fibrillation. So this arrhythmia. So what is pill in pocket therapy?
Uh,
Sir, would you please repeat?
What do you call it as a pill in pocket therapy?
Sir,
Sir,
sorry
I
for
don't
it.
know.
20 minutes are almost over.
Okay, okay, fine, okay. So okay, so just number two. Okay, which college you are from?
Yes, sir. HBTMC Mumbai.
Okay, fine, good. So have you heard of propofenone?
Yes, sir. Sir, would you please tell about the filling pocket theory?
Which one? Pill in pocket. You will
Uh,
put the pill in your pocket. No, whenever you are getting palpitation, you can take it. Okay.
okay. Okay.
That's called pill in
Okay.
pocket therapy. Okay. So there are
Okay.
so
Okay, sir.
many. Okay. So there are so many other arrhythmias where you can use what pill in pocket therapy. Okay. So what is the use of adenosine?
Adenosine is a AV nodal blocker, so it is very useful in AV nodal reentry tachycardia, where reentry mechanism is prominent,
Okay, fine, good. So
and it's a very fast acting drug. So it can be
Okay.
given by saline cheese.
Okay. You discussed well. Okay. So
Yes.
your discussion was good. So you are a final year student.
Yes, sir.
Okay. So do learn well. Okay. So
Yes, sir.
it was a nice time interacting with you.
Thanks a lot, sir. It was also a very nice learning experience for me.
Okay. Fine. Okay. Okay.
Yes,
So
sir.
it's over for you. Okay.
Yes, sir.
Thank you
Thank
so
you,
much.
session number 3. You may leave the meeting now. Sir, that was test number 2. May
Okay.
I call in test number 3?
Okay. Fine.
Hello, test number 3.
Hello.
Hello, am I audible?
Yes, am I audible?
Yeah.
All the best.
Thank you. Good afternoon, sir.
Yeah. Good afternoon. Okay. You can present.
Um, can the presenter please present?
Sorry.
You can present the case.
Okay.
Can you wait a minute? I'll ask the presenter.
Should I not do it? Presentation. Hello.
Hello, we have somebody to present. We'll make this person present. You need not
Okay.
present.
Okay.
You can have
Thank you.
Can the next case be presented, please? Presenter.
Sorry, you're not audible.
Sorry, I was not. I was calling the presenter. Not
Okay.
presenter. Sorry.
Okay. Should I present the PPT?
Hello, Munira. Can you please present? Hello.
I think the candidate can present. No problem. Yes.
Test number 3. Can you please present your slides?
Yes. Yes, sir.
Thank you and all the best.
Is the presentation there?
Okay.
Is it? So can I start?
Yeah.
Sir, so a 40-year-old male came with presentation of pallor, icterus, bilateral pitting pedal edema, and ascites. So should I?
Yeah.
So,
So
so
that is
should I?
so
Yes, sir.
no history is given here. The
No,
thing
sir.
is given to you is only a certain clinical examination finding. So
Yes,
you
sir.
have got a person who is having a 40-year-old male who
Yes,
presented
sir.
with pallor, who is having jaundice and
Yes, sir.
ascites and pedal edema. Okay,
Yes, sir.
we don't know the
Yes, sir.
history. So only
Yes, sir.
person is brought here. So
Yes,
based
sir.
on these findings, no,
Yes,
what
sir.
all possibilities we can keep in mind, and based on that possibilities, what all histories are required here.
Yes, sir. Yes, sir.
Okay, so
Sir.
you can discuss one by one. A 40-year-old male.
Yes,
So
sir.
in a 40-year-old male,
So yes, sir.
yes,
Since
go
he
on.
has anemia, jaundice, edema, as well as ascites,
He or
system.
she?
Sir,
He or
he. Sir,
she?
he's. Sir, 48-year male.
Lady. Okay. Not a male.
Sir,
Okay.
male. Sir, male.
Male. Okay, fine.
Yes, sir. Yes, sir.
Okay.
So the system localization can be done to gastrointestinal system or cardiovascular system, or or it can be even nutritional causes. So,
Okay.
sir, should I discuss one by system
Yeah.
or?
Yeah.
Okay, sir. So coming to GIT system, these four features can be present in a chronic liver disease, since pallor can be there are the causes of pallor in chronic liver disease or cirrhosis can be
Okay, you are saying that a person is so first possibility you are saying is a chronic liver disease.
yes sir.
Okay.
Yes
Okay.
sir.
Okay. So
In
chronic liver
GIT
disease.
first, in GIT one of the possibility is chronic
Okay,
liver
what is the
disease.
second possibility?
Sir, it can be due to carcinoma, and which can also lead to ascites like
Carcinoma
peritoneal.
where?
Sir, abdominal carcinoma.
Which organ you mean? Abdomen means so
Sir,
many
sir,
organs.
sir, stomach carcinoma of the stomach,
Okay,
or
CS
the
stomach.
or the peritoneum carcinomatosis.
Okay, but you
Then
won't get jaundice in that scenario, no?
yes sir. If
40-year-old
liver mets,
male.
if yes sir, yes sir, yes
Again,
sir,
liver metastasis again, usually
yes,
metastatic liver diseases usually will not present with jaundice.
icterus.
It presents with massive hepatomegaly.
Yes sir,
So here you have got a person
yes
whose
sir,
liver you can't palpate. Only problem given is what? Ascites, pallor and jaundice.
yes sir.
So if a person is having ascites, pallor, jaundice and pedal edema, so
Yes,
the what is the crux over here? That means the person is having pedal edema. Is this
yes
pedal
sir.
edema because of a liver pathology, or is because of an anemia that is producing what? Cardiac failure, pedal
Cardiac
edema? We
failure.
don't know. We
Yes,
don't know.
yes sir,
Okay. So
yes sir,
is this anemia and
yes sir,
jaundice? Is it a part of hemolytic anemia? We don't know again.
yes sir.
Okay, so here you have got lot of possibilities. So the first possibility you consider it as a chronic liver disease.
Chronic liver disease.
Okay, the second possibility could be
Sir,
would you-
any multiple valvular disease leading to cardiac cirrhosis can
okay, but
present
in
with
that
these four.
cardiac cirrhosis presents with a massive hepatomegaly.
Okay, sir.
You will have a tender hepatomegaly.
Yes,
Okay,
sir.
so possible, but no, not liver here. Liver is not given. Can you consider
Okay.
constrictive pericarditis?
Yes, sir. Constrictive pericarditis.
Can
Yes,
you
sir.
think
But
of a Budd-Chiari syndrome?
Budd-Chiari syndrome, as well as
But no,
then
liver is not that much palpable.
tender, also not tender. Yes, sir. Restrictive cardiomyopathy.
Not tender of a chronic liver disease. Okay, constrictive
Sir, sorry.
pericarditis you can consider. Anything else?
Sir,
Anything else? Suppose you are
sir,
having a periannular neoplasm. They
yes,
can
sir.
present with an obstructive jaundice and anemia.
Yes, sir. Yes, sir.
Okay, so
Yes, sir.
CS stomach also, but no liver metastasis usually will not present with what? Jaundice. So
Jaundice.
can you consider hepatocellular carcinoma? But no, age is 40 only.
Yes, sir.
HCC? Okay.
But yes, sir.
So,
But there also hepatomegaly will be there.
okay, fine. So these are the clinical possibilities which you can consider based on this finding. So
Yes,
suppose
sir.
it is a any you mentioned regarding nutrition. Which nutrition problem can present like
Sir,
this?
because I thought of pallor and icterus from a nutritional cause like chronic deficiency of vitamin B12 as well as folic acid can lead to icterus as
But
well
no,
as
the ascites is
no,
usually not a
not seen. Yes,
manifestation.
sir.
But
Yes, sir.
ascites can
If
happen
chronic
once.
severe anemia is there,
Okay.
then can present with. Yes, sir.
What are the
I got you.
mechanisms of cardiac failure in iron deficiency anemia?
Sir, high cardiac output.
Okay, what is the
Since
second mechanism? Suppose the person is having pedal edema.
yes,
Any
sir.
other mechanism for edema rather than cardiac failure?
Sir, edema can be due to cardiac causes, liver causes, or renal
In
causes,
iron
or
deficiency anemia, and I mean iron deficiency anemia.
uh,
What is the
sir,
nitric oxide theory?
sir, nitric oxide theory. That is in if there is increased nitric oxide due to its defect in excretion of nitric oxide, there will be peripheral vasodilation, and thus
Okay.
there will be interstitial
So,
fluid will flow to the interstitium and leading to pedal
so
edema.
that means suppose a person is having what? A
Yes,
person is having low hemoglobin. That means that is inhibitory to nitric oxide. So when the level of
sir.
hemoglobin gets reduced, nitric oxide will be more. So more
Yes, sir.
peripheral the permeability will be more,
Peripheral
and
edema.
there will
Yes, sir.
be edema. Okay, fine.
Yes, sir.
So that's it. So you are conceptualizing that a person can have what anemia. Suppose, do you think it is a megaloblastic anemia possible? 40-year-old male. Suppose it is a flip here.
40.
He
Sir,
should be
if
a.
he's a vegetarian, then
Suppose he
in
is a vegetarian.
vegetarian, there is
So
risk
okay,
for.
fine, fine.
Yes, sir.
So based on this, now we move on to the investigation. So
Yes, sir.
with this investigation, what is the investigation profile that is given to you?
Sir,
That we are
LFT.
given?
LFT is given, and
Yes,
routine
CBC.
blood examination is also
Okay.
given.
So what is the CBC that is given to you?
Sir, hemoglobin is reduced. It is 9.8 gram per deciliter.
Okay.
Then leukocyte count is 60,000. Then MCV is 92 femtoliter. Then total count is
Total
3,000.
count.
Total.
Okay.
No,
Okay.
sir, it is. Yes.
Total count is reduced, you know.
Yes, sir. Yes, sir.
3,400.
Yes, sir. 3,400.
So,
And ESR 8.
so you are having a person who is having a low hemoglobin, low total count, low platelet count,
Yes, sir.
and MCV is little bit high.
Yes, sir.
Is it like that? What is MCV you told? 90?
92 femtoliter.
Okay, so it is 92 only. Okay, so if it is
Yes, sir.
more, okay. So what is the scenario?
Sir,
So 3 lineage is reduced, you know.
reduce, that is bone marrow suppression can be there.
So what do you call that? 3
Alcohol
lineage.
induced.
No, what do you call that? 3 lineage is reduced is called as
Pancytopenia.
Okay, that's called as pancytopenia.
Cytopenia.
So
Alcohol.
okay,
Yes,
so
yes.
what are the reasons for a pancytopenia? Like picture in a, so we'll discuss each one by one. So can you
Yes,
get
sir.
that in a chronic liver disease?
Sir, if it is due to alcoholic etiology, alcohol itself can have a bone marrow suppression.
Okay, fine.
Then, yes.
Any other alcohol mediated hematological problem in alcoholics?
Sir, sorry, I didn't. Sir?
Any
Sir,
other
please. Yes,
any
sir.
other any
Yes,
other
sir.
hematological problem in chronic alcohol abuse?
Sir, vitamin, thiamine deficiency.
Okay, fine. Anything else?
Um,
Suppose the person presents with a triad of hemolytic anemia, hyperlipidemia, and cholestatic jaundice. What do you call it?
Sir, cholestatic jaundice, hyperlipidemia.
Hyperlipidemia and
Sir, Zeev
hemolytic.
syndrome. Sir, Zeev syndrome.
Okay, that's called Zeev
Hyperlipidemia.
syndrome.
Zeev
Okay.
syndrome. Yes, sir.
Okay.
Abdominal pain will also be there.
Yes, fine. So,
Yes, sir.
so you told it could be alcohol-induced bone marrow suppression. Fine. Anything
Yes,
else?
sir. Sir, LFT, should I discuss that?
No,
Sir,
it's the CBC. No, we didn't complete.
CBC.
Suppose what is the
CBC,
most
sir,
common?
ESR is 85
See, you told
milliliter.
pancytopenia. So, is
Yes, sir.
pancytopenia, if you are seeing in a chronic liver disease, what is the first
Yes.
thing that will come to your mind? Is the patient going for anything, any peculiar problem?
Sir, hepatocellular.
Have you heard of hypersplenism?
Yes, sir, where the function of spleen is increased. Yes, sir.
Okay, so will you get pancytopenia or the
Yes, sir.
bicytopenia? Yes. Okay, what
Sir,
are the
yes,
three
sir.
types of hypersplenism?
I don't know, sir.
Okay, it's primary, secondary, and occult.
Secondary.
Okay, so here now you are having. So what is your understanding of what is Purcell anemia?
Purcell anemia, sir, where there is the margins are
Okay, what do you call that cells?
Purcell's acanthocytes.
Spur cells are actually there will be acanthocytes.
Yes, sir.
Okay, so that's seen
Yes,
in
sir.
which chronic liver disease. What is Bursell anemia? In which scenario you will get Bursell anemia?
Sir, is it in micro angiopathic hemolytic anemias?
No. In that, no, you will. It's fragmented RBCs. No, in Bursell anemia is a feature of uremia, and Spursell anemia is a feature of chronic liver disease. Suppose now a person is having hemolytic jaundice, and
Yes, sir.
hemolytic jaundice in chronic
Yes,
liver
sir.
disease.
Yes, sir.
Any other possibility you will consider? A Coombs negative hemolytic anemia in chronic liver disease.
Sir, sickle cell anemia.
Person is having a chronic liver disease and you are having
Yes,
a
sir.
Coombs negative hemolytic anemia. Which etiology of chronic liver disease you will consider?
Sir, autoimmune. But
Okay, Coombs negative.
sir,
Suppose that person is
genetic
suppose
causes,
you suppose that
Wilson's
person
disease and
yeah, very good.
hemochromatosis. Yes, sir.
Wilson's disease. Wilson's disease will
Yes, sir.
present with Coombs negative hemolytic anemia. Suppose a
Yes,
person
sir.
is having Coombs positive hemolytic anemia and chronic liver disease, autoimmune.
Autoimmune
Suppose not
autoimmune
hepatitis.
hepatitis.
Suppose a person is having hepatitis C.
Yes, sir.
What sort of anemia he can have? Again, he can have a pancytopenia. Hepatitis B and C can have pancytopenia with chronic liver disease. Any
Okay,
other
sir.
form of hemolytic anemia, a person on treatment with hepatitis C will develop? What are the drugs given for management of hepatitis C?
Serofitin. Sorry, sir.
Have you heard of ribavirin?
Yes, sir. Ribavirin. Yes, sir.
Will it produce any hemolytic anemias?
Haven't heard, sir.
Okay, that will produce hemolytic anemia. Any other problem that ribavirin can present with? Any other form of cutaneous manifestation? Ribavirin. Okay, leave it. Okay. So this person, you are thinking that this person is having a pancytopenia and he may be having a chronic liver disease. Now,
Yes, sir.
okay. So you have got the LFT that is provided to you. So what is
Yes,
the
sir.
LFT that is likely?
Sir, the total bilirubin is 6 milligram per deciliter, and out of that, conjugated is 3.4 milligram per deciliter.
Okay.
So that means more than 50% of the total is conjugated
Okay, fine.
or
So
direct. Yes.
okay, so that is indicative of a
Sir, cholestatic obstructive hemolysis,
obstructive. Okay,
post-hepatic.
can it be hepatocellular?
Yes, sir. If there is intrahepatic cholestasis,
See, what about the alkaline phosphatase here? Is it
sir,
increased
it
or
is
not?
low. It is low.
So,
It is
so do
normal.
you,
It is normal.
so
So
do
it
you think it is
cannot be obstructive
yeah.
jaundice.
Okay,
Yes.
okay, fine. So, do you think that the amount of bilirubin is
Yes, sir.
indicative of severity of chronic liver disease?
No, sir.
So, what about childhood? Is it have they
Oh,
considered the
yes, sir.
value
Yes, sir.
of
Serum bilirubin,
okay.
prothrombin time, hepatic encephalopathy,
Yeah.
ascites, and
Okay.
it is considered.
Okay.
Yes, sir.
What is your suppose this is an alcoholic person now, and he has
Yes, sir.
consumed a binge alcohol, and
Yes,
he is
sir.
coming with a tender hepatomegaly.
Yes, sir.
So, how do you assess the severity of alcoholic hepatitis?
Sir, Medmeet score.
Yeah, what is that?
If that is, so I forgot the criteria. If
Formula
it is more than 32, we give
32. Yeah,
yes,
it is more than
steroids.
32.
Yes,
So
sir.
that is called matrix discriminant
Matrix
function.
discriminant.
Discriminant function. Okay.
Okay,
Okay.
okay, sir.
So what is the is there any auscultatory finding over the liver that you will get
For
in alcoholic
interruption.
hepatitis?
Sir, hepatic bruit can be seen in hepatoma or hepatic artery stenosis, or
Or
in sir,
or
sir, hepatic artery aneurysms,
okay or an autoimmune hepatitis.
autoimmune hepatitis. Yes.
Okay, fine. So okay, fine. So you are thinking that is this patient's LFT? What about the
Yes, sir.
albumin and globulin?
Sir, it is reversed. Globulin is on the higher side. It
Okay.
is 9.1 and albumin is 3.1.
Okay.
So there is hepatocellular failure, feature of hepatocellular failure.
Okay.
Albumin
So
is
is that indicative of a chronic liver disease?
yes, sir.
Okay. So low albumin with a AG reversal.
Higher. Yes,
Okay.
age
So
reversal.
from the
Yes, sir.
OTPT, is it more indicative of a ethanol related or is it something else?
Sir, since ALT is more than AST, it is
Okay.
not probably alcoholic cause.
Okay. Why this?
ALT is
Okay. Why this AST is more than ALT in ethanol-related liver disease?
Sir, because of deficiency of pyridoxal phosphate, and ALT requires more of this cofactor for
And
its
then
synthesis.
why this AST is more than ALT then?
Sir, because AST, one factor is pyridoxal phosphate. Also, the excretion is slower
It is actually
of
not due to a what elevation of what a see the OT is more than
def-
PT. Hmm?
deficiency of yes,
Ah,
sir.
so
Deficiency
actually
of ALT.
it is not due to what why OT is more high. It is actually due to a what the pyridoxal phosphate is
PT is
not.
more than
Uh,
OT. Yes, sir.
See, then so suppose from the LFT,
Yes,
uh,
sir.
suppose now a person is having a is ALT and AST more than thousands,
Yes, sir.
more than thousands.
Yes,
Okay,
sir.
so what are the scenarios where you will get this ALT, AST in
Acute,
thousands?
sir, acute viral hepatitis.
Okay, then
Yes. Then,
then
uh,
then poisoning.
yes, sir. Acetaminophen poisoning drug.
Anything else?
Herbal poison. I mean,
Okay, anything
herbal
else
drugs.
which is more common?
Uh,
Have you heard of rat poisoning?
yes, sir. Zinc phosphide poisoning. Yes, sir.
What about
Yes, sir.
Budd-Chiari syndrome? The
So, Budd-Chiari syndrome.
arterial
Sir,
and venous infections. And arterial and venous infections, the OT and
sir.
PT high.
Since there is a hepatic venous thrombosis, there will be if there is damage to hepatocellular hepatocytes, then there will be
Yeah. So
increase.
what is the first liver cell among the LFT? Which
Yes,
marker
sir.
will be first deranged in acute liver failure?
Sir,
Is it the bilirubin or something else or anything else?
sir, is LFT or can we that like prothrombin time can
Yeah,
it will increase
that's again a
prothrombin?
liver function test.
Pro,
Na? That's what I asked.
yes, sir.
Yeah,
Prothrombin
it's
time will be increased
uh,
first.
very good, very good, very good. So
Yes, sir.
why?
Sir, because prothrombin time because there is vitamin K is produced
What is
in
the
the
half life? It's only 4 hours. That is
4
why
hours.
acute liver
Yes.
disease. No. So what is the
Yes, sir.
definition of the acute liver failure? Or
Sir,
can you say even in Korean?
encephalopathy plus coagulopathy within encephalopathy with or without coagulopathy manifesting within 6 months of
6 months.
before 6 months. Sir, if it is hyperacute, it is within 7 days. Then acute means 7 to 28 days, and then more than
Yeah.
28 days. Yes,
Subacute and more than 6 it is chronic. So that
yes, sir.
means any forms of altered sensorium with
Yes, sir.
coagulopathy, that means more than 1 point in a person. Okay, in a
Yes,
person
sir.
within 7 days of onset of jaundice, it should develop
Yes, sir.
within 7 days of
That
onset
is
of
fulminant
jaundice.
or yes, sir.
In a person
Ful.
who is not having a pre-existing chronic liver disease,
Yes, sir.
and the exceptions being three. Which are those three exceptions?
I am
One
not
is
aware, sir.
okay. The
I
three
don't know.
exceptions are vertically transmitted hepatitis B. Second is
Okay, sir.
autoimmune hepatitis, and third is
Okay.
Wilson's. So three
Okay, sir.
vertical
Okay, sir.
exceptions. Okay, that is the classical definition
Exceptions.
of
Yes, sir.
liver
Yes, sir.
failure. Okay,
Yes,
so
sir.
how you are going to treat a person with a varicose bleeding?
So varicose bleeding, if there is shock, then we should first of all maintain the blood volume. Then
Okay.
we can do endoscopic varicose ligation
Okay, what
or
drugs you can provide?
So
What
drugs
drugs?
like yes, sir. So octreotide, that is somatostatin,
Okay.
and then analog, then
What is the
terlipressin or
problem with
glypressin.
octreotide? What is the problem with octreotide?
Sir, serious
Coronary steel
coronary
can happen.
steels. Yes, sir.
Okay,
Yes, sir.
so
Yes.
suppose you give a very large dose, no person who are highly prone for coronary artery disease, that is dangerous. What
Yes,
is the
sir.
any other problem with the drug? What is tachyphylaxis?
Tachyphylaxis. There is initially the effect of the drug develops fast, then it goes off.
Okay, so is octreotide a drug like that?
I don't know, sir.
Okay, So, okay.
I will
So
write.
you
Yes,
told.
sir.
So, what are the predictors of varicose bleeding?
So predictors.
You have got non-invasive and non-invasive and invasive predictors. Which are those?
Predict. I don't know. So predictors.
Predictors means no. Suppose a
Uh,
person is having chronic liver disease, he is asking you, "Am I a candidate prone for developing a varicose bleed?" So how
yes,
can we
sir.
say with the
So grading
investigation?
can be done with endoscopy. Grading.
Okay.
Yes,
So the
grade 1, grade 2.
see the child book A, the chance for developing varices is only 15. B means it is
15.
50, and C means it
Okay.
is 85.
Okay, sir.
Okay, suppose a
Yes,
person
sir.
is having thrombocytopenia, that is again high chance. The size of
Okay,
portal
sir.
vein is another parameter, and the
Okay,
transient
sir.
elastography of liver by fibro testing. Okay, so there are how
Fibroscan.
many? Yeah.
Yes, sir.
What is
Yes, sir.
what is watermelon stomach?
Sir, it is seen in gastric antral vascular ectasia, where
Okay.
there is a
What is
where there
snake
is
skin
a
appearance? What is snake skin
sir.
appearance?
It is seen in a portal hypertensive gastropathy.
Okay.
Yes. Yes.
So
For the introduction, we are nearing 20 minutes. Thank
okay,
you.
okay, fine. So suppose now a person is coming with hypokalemia and chronic liver disease. What are your possibilities?
Hypokalemia.
Hypokalemia.
Uh,
Any
sir.
etiology specifically you will think of? A person
Hypokalemia.
is having renal tubular acidosis, hypokalemia, and chronic liver
Sir,
disease.
yes, sir. Syndrome. The renal. Yes, sir. The syndrome is called.
It's not a syndrome. Any scenario? Okay, leave it. Suppose now a person is coming with history of. Okay, so
Yes, sir.
scenario. A person is coming with history of libido reticularis,
Yes, sir.
and the person is having a chronic liver disease. How can you
Yes, sir.
correlate?
Sir, any drug causing that libido reticularis?
Or
The,
any condition that produce libido reticularis and cirrhosis? Have you heard of hepatitis C? What are the
hepatitis C.
extra
Yes, sir. Sir,
hepatic ah,
cryoglobulinemia. Yes, sir.
okay. What are the extra hepatic manifestations of hepatitis C?
So one is
Cryoglobulinemia.
cryoglobulinemia.
Second
Then
is
hepatitis C.
hmm. Have you heard of MPGN, oral lichen
Yes,
planus?
sir. Yes, sir. Yes, sir.
You might have
Yes.
heard
Mesangial
of. Ah,
proliferative glomerulonephritis. Yes, sir.
okay, so okay, so
Yes.
these are the extra. What is the extra hepatic manifestation of hepatitis B?
Sir, polyarthritis nodosa.
Okay, fine. Suppose
Yes,
now
sir.
you are having a person who is coming with history of foot drop bilateral, and he's having bronchial asthma,
Bronchial asthma.
and he is having bilateral foot drop, and
Foot drop.
certain plaque-like lesions over the skin. His absolute eosinophil count is more than 1,500. What is your diagnosis?
Sir, Churg-Strauss.
Okay, Churg-Strauss, fine.
Churg-Strauss.
Now,
Yes, sir.
yeah, fine, fine. Okay, suppose now a lady is coming with history of uh, sensory ataxia,
Okay, sir.
and she is complaining of difficulty in swallowing, and she is also
Sensory
having
attacks and difficulty. Yes, sir.
she is having difficulty in swallowing, and she is having dry mouth.
Yes, Sjogren's syndrome.
Okay, so
Dry mouth, dry.
how will you explain sensory ataxia? One of the neurological manifestation of Sjogren
Manifestation
is
is yes, sir.
sensory ataxia. Yeah,
Yes,
fine.
sir.
Suppose now, what is your
Neuro.
understanding? What is balaclava helmet phenomenon?
Sir, it is that the spinal tract of the fifth nucleus, the caudal portion of it supplies the near the nose, that nose
Okay.
disc, and the caudal lower portion supplies the periphery of the face. So that is
Okay.
about the balaclava helmet phenomenon or
Okay.
onion peel appearance. Yes.
Okay. Fine. Fine.
Yes.
So, uh, one uh, one more thing in management that I would like to know. Suppose now a
Yes, sir.
person is coming with history of uh, altered sensorium.
Yes, sir.
Okay. person is
Yes, sir.
coming with altered sensory means seizures. Okay,
Seizures.
so
Yes, sir.
seizures. What all
Yes, sir.
blood investigation is required to know the reason of this altered sensory means seizures?
Okay, sir. Blood, first of all, routine blood examination involving all electrolyte
Okay,
levels,
which all
blood
electrolyte?
sugar. Yes, sir.
Which all
Then,
electrolytes?
sir, sorry, sir, sodium,
Okay.
magnesium, calcium.
Uh,
Yes, sir.
then is it
Then
potassium?
potassium, but it causes paralysis like syndrome or
Yeah.
CVS, more affection, not much of stroke causes. Yes,
Okay, fine, very good. Okay,
yes,
so
sir.
okay, okay, so
And
that was a
hypoglycemia. Yes, sir. Okay,
okay,
sir.
fine. Okay, so that was a nice discussion. Okay,
Thank you,
uh,
sir.
okay, so thank you
Thank
for
you, sir.
cooperating, and
Thank you,
your
sir.
answers were good. Okay,
Thank you, sir.
okay, so shall we wind up?
Yes, sir.
Thank you so much. But we leave the meeting now.
Okay. Thank you.
That was the last participant of the event. And with that, we have come to the end of this event. I would like to thank Dr. Danish for joining us today beside his busy schedule. I would also like to thank Dr. Jayesh for judging the last session. Both the live sessions will be soon uploaded in the webinar. Finally, I would like to thank the participants and audience for their time and patience. Thank you for all. Hope you have a great day ahead. Results will be announced. For more updates, please check our Instagram account, Medmeet.
Okay, thank you. And all participants have done very well, and it was a more of a, I think they are beyond what um, the undergraduate level. Okay, so thank you.